Okay, guys, let's do a case study. It's been a while since we've done clinical stuff, and I know we talked a lot about sales and the shift, but let's get back to doing some case studies. So I want to go over a case study with you. I think we've talked about this patient before, but she had a huge flare-up. So I want to talk you through what happens when you're getting good results with a patient, you think you're ready to discharge, and then boom, everything blows up. What happened? Why didn't it work? Okay. So this patient is a cheer patient with a hip problem, which I started seeing probably in like September. Came in and kind of sort of maybe looked like a labral acetabular tear problem. Started working with her and she cleared up pretty quick. So she went from not being able to do really anything at cheer to going back to cheer within 2 visits. Everything felt fine until she started doing certain movements. Okay, so we've talked about this before, and this is a huge component of the 180 system, and this is a huge component that they completely miss in PT school. Okay, so the important thing when I'm evaluating her and I'm listening to her tell me what positions don't feel good, what positions she fails, that kind of stuff, it's not where the pain is. Okay, so if you have a shoulder patient come in and say, my shoulder hurts here or here or here or wherever, when I am in that position, it's not where the pain is that you should be paying attention to. It's the position that their joint is in and the direction it's going. Is it an eccentric contraction or is it a concentric contraction? Okay, that is much more important than the location of the pain. So anybody who says, well, where does it hurt? Okay, let's go treat that spot, just completely got screwed up and the patient's not going to respond. Okay, you might get response as far as reduction in symptoms because they say, oh, my shoulder hurts there, and you go do stem and heat and ice and K-tape and cupping and needling and stretching and soft tissue release and blah, 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 whatever. So yeah, that stuff will make that feel better because you're overloading the proprioceptors to feel tactile stimulation or electrical stimulation or needles or whatever. And so they'll feel better until about an hour later when everything comes back, which is what people say happens with physical therapy all the time. Okay, so it's not the position. So when we're talking about this patient, when I'm running her through the screen, she can touch her toes, she can lean back, she can turn, she can squat. She's got pretty much no problem. So when I ask her, what is it at cheer that bothers you? And she says, well, when I do this, and then I have to think, I have to use my critical thinking skills, which you'll learn on the shift. I have to use my critical thinking skills. How can I replicate that position eccentrically or concentrically now in the clinic with a clean environment? So I have her do a little step over with rotation movement, and she was like, yep, there it is. So she could touch her toes, she could lean back, she could trunk rotate, she could full depth squat, she could single leg squat, she could march in place, she can do hip abduction, she could do adduction, no problem. But when I have her do a step over, which not only has abduction, but also rotation, now we have the symptoms come back. That's the important thing. What position was her hip in an abduction and internal rotation or external rotation? That's what I got to figure out what's not working there. Okay. Now you might be thinking, well, if she has a labral tear, obviously the labral tear is the problem. That's why she has pain in that position. And you would be partially correct. Okay. So let's see why that's only partially correct. Okay. So let's reverse. So she was coming in, doing fine, doing well. We got her totally pain-free. So now I'm going to take her in the gym. We've gone over this before in the Facebook group. I'm going to take her in the gym and I'm going to fatigue her and see what happens or how fast or what causes her fatigue. Okay, so we do lunge walk with a twist, crossover walk with a squat, weighted squats, full depth squats, no problem. We do some vertical jumps, no problem. We do A skip, no problem. We do B skip, no problem. We do C skip, and boom, there's the symptoms back. Because what does C skip have that none of that other stuff has? Abduction and rotation. Okay? So once again, I just put her back together. I went through a bunch of stuff that included checking abduction, checking internal, external rotation, clean that stuff up. Now she does C-skip, boom, pain comes back. What do I do? What would you do? Think about that. What I would do is put her back on the table and figure out which one of the muscles that I just worked on is now inhibited again. So when I put her back on the table, we go to deep hip rotators, so gemellus, quad fem, obturators, fail, 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 pain, pain, pain. And before I took her in the gym, I just worked on those things and those were all passing. Okay, so I go back, treat those. Trying to think if I treated anything else. Might have treated psoas, major, and then take her back in the gym, redo, just go right to C-skip. How's that? That's better. Okay, but I know if I have her keep on doing that, we're gonna fatigue again. So now think, okay, we figured out gemellus, obturators, quad fem, psoas major. So those are the ones that are the big ones for her that start the ball rolling and everything comes unraveled. Okay, so what are we gonna give her for a home exercise program? Think about it. What is going to, when she's by herself, her problem isn't gross strength. So remember, we're not dealing with a gross strength issue. We're dealing with a facilitation issue. How do we reverse inhibition when they are on their own with a home exercise program?